Welcome everyone. My name is Cindy Lowen. I'm a Medical Affairs Manager with Nestle Health Science. I'm thrilled to introduce today's speakers and assist with the webinar entitled Use of Peptides for Optimizing Enteral Nutrition Delivery, GI Tolerance, and Metabolic Management. I'm very pleased to present today's speakers, Dr. Pepe Saavedra and Dr. Juan Ochoa. Dr. Saavedra is currently an Associate Professor of Pediatrics at the Johns Hopkins University School of Medicine. He is a pediatric gastroenterologist, investigator, educator, and medical and scientific business executive whose experience spans the globe. His extensive publications are in the area of pediatric nutrition, intestinal microbiota, immunity, and preventive nutritional strategies, including a recently published book dedicated to the impact of early life nutrition on lifelong health. A past medical director and chief medical officer for Nestle Nutrition, Dr. Saavedra is currently chairman of the board of the Nestle Nutrition Institute. Dr. Juan Ochoa is currently the medical director of the SICU at Ochsner Medical Center in New Orleans. He is a surgeon and physician scientist whose extensive publications focus on the functional effects of arginine deficiency on T lymphocytes and nitric oxide production, and is fondly nicknamed Dr. Arginine. Dr. Ochoa was a chief medical officer for Nestle Health Science and currently lectures nationally and internationally, passionately advocating for the optimal nutrition care of all patients. It is my pleasure to now hand this webinar over to these esteemed physicians. Dr. Saavedra, please feel free to begin.
Thank you very much, Cindy. It's a pleasure to be with you, and thank you to all the attendees. I hope we're able to deliver, even though it's a fair amount of material. I understand you will have handouts for this, so and dive into further detail. But I do hope we're able to deliver some basic concepts and some practical ideas that we can review at the end. So I don't think I need to tell this audience that enteral nutrition is critical and paramount to the successful medical management of compromised patients. And for that purpose, and the reasons for this are ample, well known by others, and we still continue to discover reasons for this approach. We do know that not only nutrition support, but enteral nutrition in particular is the preferred route for nutrient delivery, but it is not always easy to do. Challenges need to overcome. There's a number of factors affecting GI function, anywhere from the oxygenation and perfusion of the patient to the changes in microbiota during critical illness, changes in motility, as well as the lack of nutrient, all which lead to physiologic consequences, including motility problems, maldigestion, malabsorption being a key component of these negative physiologic consequences, and of course loss of mucosal barrier and immune function. All this manifested into clinical consequences which affect the morbidity and mortality outcomes of these patients. Among these consequences is GI tolerance. This intolerance, which happens in many of these patients, sometimes leads to further withholding of enteral nutrition, which in itself increases these physiologic consequences and leads to a iatrogenic negative vicious cycle, which is sometimes hard to break. Now, GI intolerance is a consequence of this dysfunction, and particularly malabsorption are very common in critical care patients and as well as chronic care settings. The various studies document the fact that intolerance, upper and lower gastrointestinal problems occur in 30 to 60% of patients. This, including the malabsorption associated to this intolerance, is both the cause and the consequence of poor absorption and utilization of nutrients. Now, the frequency and the consequences of GI tolerance are been documented in a number of epidemiologic studies. This is amongst the most broadly quoted, more recently, large international study, 167 ICUs, close to 2,000 patients, documenting the fact that intolerance happens in at least 30% of patients in the ICU, and it is associated with lower delivery of nutrient, fewer ventilator-free days, and importantly, an increased ICU stay with its attendant increase in mortality. Particularly as it relates to ICU stay, roughly a 3.1 day difference has been documented in patients who develop intolerance of the GI tract versus patients who do not. Now, all this, of course, has led to a number of guidelines written by a number of organizations. These are the SCCM Aspen guidelines for provision of nutrition support, which clearly recommend the therapy of nutrition support should be instituted early, within 24 to 48 hours in critically ill patients, and that enteral nutrition is and should be considered superior for initiating it in these critically ill patients whenever they need supportive therapy. Both decreases in mortality and morbidity are associated with this approach. So providing early, that's the when, enteral nutrition to critically ill patients isn't not a question of if, it's really more of a question of how, what, and how much. If we're to discuss or begin discussing how it is that we need to deliver nutrition, we have a number of approaches, including the same guidelines from SCCM that recommend that enteral nutrition and feeding protocols be designed and implemented in this population, and that we should try to adhere to them, and that we should clearly have targets. Most of the time, targets are done based on what the patient can afford in terms of rate of feeding. Volume-based feeding protocols are a much cleaner and more practical approach to being able to deliver, sometimes even close to what we are targeting. In other words, you need a feeding plan. One of the better examples of feeding plans is the PEPA protocol, or the Protocol for Efficacy of Enhanced Protein and Energy Provision. It's quality improvement collaboration, which was promoted and reported in various papers by the Canadian group, by Daryl Hyland's group, where a protocolized feeding plan that starts early, that targets a volume of feedings, and that starts with a formulation that has a maximum chance of both tolerance as well, and very importantly, of adequate absorption of nutrient, and then progress to a polymeric diet. And this is a topic that we'll expand on further, i.e. starting with a peptide-based formula rather than intact protein. Also, tolerating higher gastric volumes so that we don't have simple or too easy excuses to stop enteral feeding, as well as starting motility agents and protein supplements as early as possible rather than delaying this initiation. Now, we're not going to be able to discuss all nutrients and all the components of nutrition that would need to be delivered as it relates to the what, but let's, at the very least, discuss, and you'll hear a little bit more about this in Juan's presentation. We need to deliver energy, and we need to deliver protein. Now, this is a very nice review from Zussman's group in Israel, looking at almost 12 years of enteral nutrition, more than 1,000 patients in the ICU, which best captures the current understanding and the trend towards what we need to deliver and how much of energy and protein we need to deliver for patients who are critically ill. On the left side is the adjusted 60-day mortality versus the delivered energy, the calories delivered to critically ill patients. Nothing new on the left side. It's very clear. You starve a patient and you do not deliver enteral nutrition early in the process, mortality is very high. As you start delivering energy, mortality does decrease. However, there seems to be a particular point at which in excess of the energy that can be metabolized and utilized by the individuals starts increasing mortality. In other words, the delivery of energy for patients needs to be moderated, and excesses of energy may actually lead to negative outcomes. On the right hand is the same 60-day mortality compared or correlated to protein intake. And here, the protein target of 1.3 grams per kilo per day is that 1.0 line. Same thing. You don't deliver protein, mortality is high. As opposed to energy, though, this is almost a linear correlation. The greater the protein you deliver, the lower the mortality. So aiming for energy and protein delivery that increases the chances for successful outcomes in a relationship that maximizes or minimizes the complications is what we can and should be seeking. When we focus on protein, the delivery of adequate protein is, as we said, critical to these outcomes. Again, this is, in this case, a prospective multi-center study, more than 50 intensive care units in about 15 countries, looking at the delivery of protein and 60-day mortality. As you can see from the bars, delivering less than adequate protein, less than 20% of what the target was for these ICUs, the mortality is the highest. The white bars, delivering more than 60% of the target, the mortality is the lowest. And this difference, of course, is magnified in patients who are more severely ill. Now, to deliver the protein, we need to know what or how we need to incorporate it into the feedings of patients. Today, our choices are relatively limited in the sense that for critically ill patients in particular, our protein sources include bovine proteins like casein and whey, and the soy proteins in some very small number of products that are available internationally. Technology has allowed the hydrolysis of proteins with enzymatic approaches similar to those that would happen in gastric or pancreatic digestion that yields a range of large, mid-sized, and small peptides, which we'll discuss a little bit further, as an option to providing only intact proteins. And of course, you can also feed with crystalline amino acid solutions. Now, in terms of protein choices, as we mentioned before, these are whey, casein, and soy are the most common sources that can be used for commercial products that to deliver enteral nutrition. These are the WHO and FAO markers or measures of protein nutritional quality of whey, casein, and soy, as you can see pretty much across the board in terms of biologic value, protein efficiency ratio, which is the weight gain per gram of nitrogen consumed in animals, and protein digestibility. Whey, casein, and soy in that hierarchy are the measures of, or have its measures of nutritional quality. We don't have time to discuss a number of other effects or characteristics of whey protein, including the fact that it has abundant leucine, which favors muscle protein synthesis, cysteine, which increases glutathione to protect against free radical damage, and also empties better from the stomach than other proteins, in particular casein, bovine protein. What I'll spend a little bit more time is in discussing what or how the absorption of dietary protein and the physiology associated to can or could help us decide approaches to nutrition in terms of what types or protein sources we can deliver. Everybody's familiar with gastric digestion and pancreatic proteases, all of which ultimately yield polypeptides that are at a high concentration in the lumen of the intestine. Now, intestinal peptidases, which are highly prevalent in all the apical surfaces of the brush border of the enterocyte, are the ones that in the end take these peptides down to single free amino acids and di and tripeptides. Now, not until too long, until the mid-70s, it was well described that free amino acids were the ones who were transported into the enterocyte by a number of transport mechanisms. So about a dozen specific transport mechanisms have been described, all of which work with different solutes in terms of chloride, protons, or potassium, or sodium, to transport specific amino acids or specific families of amino acids into the enterocyte. However, in the last couple of decades, it's become increasingly clear that the bulk of amino acid intake into the enterocyte is in the form of di and tripeptides. And this absorption into the enterocyte cytosol is carried out by the peptide transporter number 1, or PEPT1 SLC15 transport system. This particular system is the one that actually bears the brunt of the transport of amino acids into the enterocyte, which allows amino acids infused in the form of peptides, di and tri in particular. Tetrapeptides are not transported, and being much more effective than the individual free amino acid transport. This provides a very highly effective and safe redundant mechanism not to rely on specific amino acid transporters. Now, these di and tripeptides are ultimately hydrolyzed by intracellular peptidases into amino acids, and we are now starting to describe the possibility that there are some basolateral enterocyte transporters that may actually transport some di and tripeptides into circulation. However, it is also important to state that many of the amino acids that are incorporated into the enterocyte cytosol not only serve to be transported into circulation, but more importantly, serve as the critical fuel for the enterocyte itself. And depending on the protein, depending on which part of the intestine, up to 30–40% of the amino acids serve to maintain the function of the enterocyte so that it can continue digesting and absorbing, as well as continue transporting, so that the individual gets amino acids into circulation. Again, when we provide enteral nutrition, we're not only providing enteral nutrition to the multiple organs outside the gut, but importantly to the gut itself. And more recently, as I said, some evidence that some of these di and tripeptides can be absorbed is starting to be described. Just take a couple of minutes, because I do think that some of the characteristics of the PEPT1 transporter system are very interesting and actually have some potential implications in clinical practice. This is a protein. It's not that large. It's about 700 amino acids. It does have some extensions that go into the intestinal lumen, and you find it at the apical border of the enterocytes. This transporter is an archaic transport system. It's actually found in many species, including invertebrates. So it was developed evolutionarily very early, helping the internal milieu of both invertebrates and eventually vertebrates to absorb a fair amount of nitrogen for utilization from the environment. This transporter is mainly expressed in the small intestine. The more proximal, the more expression. And it's very effective and non-specific. In a way, and some call it, it's almost a promiscuous transporter, because it is effective in taking all, or most, if not all, the potential variation of dipeptides, which ends up being about 400 different dipeptides from the 20+ amino acids that could be available, all the way to the 8,000 different tripeptide sequences that are possible with different amino acid composition. So this particular transporter is not only effective, but is very efficient, because it'll bring all kinds of amino acids in the form of di and tripeptides, as opposed to the single amino acid transport systems. Now, interestingly also, the transporter expression of PEPT1 is increased with high protein diets. So there's a positive feedback response and mechanism by which the transporter, when provided with more nitrogen, will absorb more nitrogen. And at the same time, starvation can also increase the PEPT1 transporter. Interestingly, for example, this transporter is not typically expressed in the colon, but in patients with short bowel syndrome, you can actually find PEPT1 transporter expression in the colon. Similarly, it's been found in some IBD patients. So This particular mechanism does allow for a very significant physiologic approach and rationale for the provision of nitrogen in a way that is more effective for a population of patients such as the critically ill. And finally, it is also interesting, this transporter has this peptide mimetic transport capability by which a number of antibiotics, particularly beta-lactams and cephalosporins, can be absorbed into the enterocyte, as well as other agents, including antiviral agents and ACE inhibitors. When we look at utilization of whey proteins, and particularly providing whey proteins in the form of peptides, this is just one example. On graph B, you can see the increase over time of leucine when subjects are provided with an oral meal of whey protein that has been hydrolyzed into peptides. That's the highest curve. Soy protein or casein proteins. And on the small insert, you see the area under the curve, the total amount of amino acid, in this case leucine, transported with different protein sources, whey hydrolysate being the most efficient. When it comes to the possibilities of delivering protein, again, these are just examples, but these are the more commonly commercialized enteral feeding formulations, and this is a gel electrophoresis showing the different profiles of protein and peptides in these three different formulations. The orange line is the molecular weight of alpha-lactalbumin, which is one of the smallest bovine proteins that we have available. Everything above that orange line are large peptides and intact proteins. Everything below that lower line are smaller peptides. As you can see, there's a very significant difference in the amount of peptide, and particularly diantripeptide, of formulations including whey-based protein hydrolysates versus those peptides in other hydrolysates, and of course intact proteins to the right, that have much higher molecular weight proteins requiring digestion. The very dark blue bars that you see in those are mostly casein intact protein. So just looking very briefly and rather summarily at some of the clinical evidence that's being slowly accrued, some initial reports will show a couple of these, and some studies looking at comparing some approaches to delivering protein in an intact form versus a peptide-based formulation. This particular small retrospective study looking from Canada, looking at adult patients in long-term care who went from intact protein to peptide-based formulations, is showing very significant improvement in tolerance in this small number of patients, and pretty much all gastrointestinal types of intolerance, as well as the reduction in the medications that were used for intolerance symptoms in these patients. Similar retrospective small study, but in this case in developmentally delayed children receiving intact protein enteral feeding versus partially hydrolyzed whey peptide-based formulas, again showing a reduction in symptoms over time. 92% of the patients in this case improved their tolerance, and the majority of that happened in the first few days of the switch. This one is from Mayo Clinic, in this case in home enteral nutrition patients. Again, mostly these are mostly examples of chronic care patients receiving one or other formulation, which allows the study of retrospective study of comparison from switch from one protein source to another. Here again, very significant decrease in the overall number of GI symptoms and intolerance. Again, the numbers continue being relatively small, but quite demonstrative. And in this particular case, they actually measured the use of healthcare resources, showing a reduction in patient-initiated calls, ER visits, and scheduling of provider visits. The majority of the peptide-based formulations in this case were whey-based protein formulations. Looking at slightly larger studies, again, these are all, as everybody is familiar, relatively difficult to do. This study out of Taiwan, again, this is also a retrospective study, in this case in ICU patients, looking at or comparing patients who received intact protein versus a protein hydrolysate or peptide-based formulation, in this case roughly with 16% protein. All of these patients were hypoalbuminemic as part of the criteria for inclusion, and they demonstrated a significantly higher serum albumin by day 10, serum prealbumin by day 5, and then higher total lymphocyte count. Lower gastric residuals in those patients on peptide-based formulas, no difference in diarrhea or infections in this particular study, and again, the tolerance appeared to be the same or better across the board. Another paper, in this case, a study from Bern in Switzerland, one particular ICU, providing, in this case, a prospective, a randomized way, intact protein versus peptide-based formulas, in this case, a higher protein formula, showing that, again, you can deliver a higher amount of protein in these ICU patients when you use a higher protein peptide-based formulation. No difference in incidence of diarrhea, which was the primary outcome in this study. One of the problems with this one is the stool events were not defined as we typically define them. They're health caregiver defined criteria. Nevertheless, the difficulty here was with the fact that stool collectors were used very prominently. But nevertheless, no difference in the relatively small numbers of diarrhea that these patients had. And the occurrence of diarrhea, on the other hand, in general, was associated, as we said before, with negative outcomes, in this case, length of mechanical ventilation and length of ICU stay. The days of enteral nutrition interruption in these patients, though, was lower for the patients getting peptide-based formulations. And then lastly, this is another ICU study, in this case also a prospective randomized trial. Here again, very similarly, critically ill patients, in this case medical and surgical, receiving peptide-based formulation, high level protein, 25% protein, versus intact 18%, which is typical and standard use in many ICUs, showing that, again, you're able to decrease the total number of gastrointestinal adverse events, though no clear definition of a specific individual events being less in one group than in the other, and they did not report in this particular case the enteral nutrient delivery. Now, lastly, one consideration in decision making, of course, has to do with enteral feeding costs. There's a number of ways to approach this, but again, as we accrue some additional clinical experience in clinical trials, we should be able to better characterize the potential that there can be accrued cost savings. This particular paper actually took one approach, first estimating the cost of GI tolerance. Using the Gongavison paper numbers that we mentioned before, and looking at 100 patients with a median ICU stay of 3 days less if they were not intolerant. Obviously, in 100 patients, there will be a 96-day difference in length of ICU stay if the population developed, 31% developed intolerance, and that meant an increased amount of cost of $453,000 in 2018 numbers for the United States. So what they did is took a health economic cost consequence modeling approach to calculate at what point can or would intact protein formulas result in cost savings. And through the reduction of ICU stay, if only 7% of the GI intolerant patients were avoided, that alone was sufficient to match the potential increased cost associated with peptide-based enteral nutrition. So lastly, and Juan will be talking a little bit more about the metabolic consequences of the amounts of protein and energy that we deliver. I go back to this graph, which I think is quite informative in terms of how we should be thinking about what we deliver in terms of enteral nutrition to these patients. It's very clear that the goal of energy and protein needs to moderate the total amount of energy delivered, understanding that certain maxima are possible, and we should probably not exceed them, while at the same time, we need to maximize the delivery of protein. We need to maximize the quality of protein and the delivery of protein in a way that maximizes its digestibility and absorbability by the GI tract. The goal ultimately is first to improve the GI immune function, its absorbance capacity, its decreased chances for intolerance, all of which in theory will or should contribute to improvements in morbidity and mortality of this population. So to conclude, first, it is important to do this, to do it early, to have a plan to deliver enteral nutrition because it will improve outcomes. Early in enteral delivery of adequate energy, maximizing protein delivery increases chances for better outcomes. Higher protein formulations will allow the right balance of energy and protein to meet the needs of critically ill. Whey hydrolysates with predominance of small peptides can deliver a high quality protein, facilitate absorption, and decrease chance for intolerance, particularly in this population. And it can also save money. So I'll pause there and pass it on to Juan, and hopefully we have time for questions at the end.
Thank you so very much, Pepe. Let's talk about the use of peptide-based formulas and optimizing enteral nutrition. And I'm going to make emphasis on an organized way of approaching the creation of evidence, that going from understanding the basic concepts to then analyzing the metabolic management of the patient and the metabolic consequences of what we feed, and then looking at clinical outcomes. So let's dive into this. If I were to simplify nutrition in one graph, which I know is very difficult, I would say that the traditional goal of delivering nutrition has been that of providing optimal amounts of nutrients that give us the best physiologic functions and clinical outcomes. However, particularly in critical illness and acute illness and in some chronic illnesses like cancer, we know that the provision of goals seems to be insufficient to prevent the progression of malnutrition. For those that are of us that are a little bit older, we remember those days when we said, well, maybe what we need to do is give more. And we call that hyperalimentation. And again, those of us that may remember those days, we were delivering caloric goals at 35 kcal per kilogram per day or more. And we know at that point that the results were quite literally disastrous. We not only did not prevent the progression towards malnutrition, we actually caused so many side effects as to increase morbidity and potentially mortality. So hyperalimentation was then eliminated. Then the question becomes, what is the goal? How many calories should we give to a patient, and how much protein and other micronutrients? And within the last 10 to 15 years, the question of a caloric deficit was raised in the literature. How much is it that we could and should allow the patient to not meet their goals, or should we allow ourselves to not meet goals, particularly in calories, versus how much should we really meet? And that line between a goal and a caloric deficit has been studied systematically in the last 10 to 15 years. In 2005, Jody Brick, then a student at my laboratory at University of Pittsburgh, and I did a retrospective analysis on outcomes in our intensive care unit with the intention of demonstrating that meeting amount of calories was going to be important in outcomes, and that if we did not meet those calories, we would see poor results. To our surprise, we saw just the opposite. People that where we met lower amounts of calories seemed to do better, seemed to have shorter lengths of stay, better glucose control, and better outcomes from the need for inpatient rehabilitation. A number of studies did study this question in the last 8 to 10 years in a systematic fashion in prospective randomized controlled trials, and you see a list of those trials there, ranging from the APANIC trial in 2011 to the early goal-directed nutrition work by Allingstrup in Denmark in 2017. If you look at the outcomes, there is essentially no benefit in outcomes if we focus only on delivering calories. In fact, only one of these studies by Heidegger shows a benefit, and that is in patients that were already failing to receive enteral nutrition and had significant intolerance, as Pepe had said before, for over a week or longer. So there is no clear benefit if we give the calories to reach what we would think is the caloric goals or needs of the patients. In fact, in this study by Mathilde Allingstrup, a single center study, what she demonstrated using indirect calorimetry as a way of achieving early goal-directed nutrition was that compared to a standard of care, and those patients did receive lower amounts of calories, there was no difference in outcomes. But there was one metabolic difference that stood up, which was that those patients that received more calories through early goal-directed nutrition had significant amounts of hyperglycemia, and that the incidence of hyperglycemia in that group was dramatically increased. Now, in fact, if we go back to all these studies that I showed before, most of these studies demonstrate that by feeding to traditional caloric goals, we increase the incidence of hyperglycemia. Now, who cares? At the end of the day, hyperglycemia is present in up to 86% of the patients, as demonstrated by different studies in adults, and up to 64% of children. So if that is the case, all we need to do is just give some more insulin. However, there are a number of studies that have shown that hyperglycemia is not only an observation in the intensive care unit, it is a direct causative factor of poor outcomes. Higher levels of blood glucose are associated with higher risk of mortality, higher risk of infections, increased length of stay in the ICU, and an increased utilization of healthcare resources in the ICU. That is demonstrated by a nice evaluation and review done by Jean-Charles Preiser, showing that all these effects on the y-axis, renal replacement therapy, transfusion, ventilation, hospital length of stay, etc., are all affected negatively by hyperglycemia. And look at the number of patients studied. In some cases, up to 500,000 patients in glucose levels measured. And so this is not a small sample size. Hyperglycemia indeed is an independent predictor of poor clinical outcome. And so we need to pay attention to it. So we have reached the conclusion that reaching caloric goals is not important, at least in the first steps in the first week or so in the intensive care unit. And thus, we need to start thinking, what do we feed and how do we feed? It is important to start feeding early, but how do we feed the patients now, and what should we feed them? And there are two philosophies that are now approaching this idea of feeding lower calories. The first one we call permissive underfeeding, where we do not achieve any nutritional goals. We say lower calories, lower protein, macronutrients are not that needed, but we give something to maintain gastrointestinal trophism. It does have the interesting benefit that it facilitates a starvation response, and those proponents of permissive underfeeding say that is actually physiologic and should be promoted. But then the question becomes, for how long? How long can a patient compensate being underfed? And the answer so far seems to be for a week or so. Other groups suggest, well, the problem is calories, so let's focus on not giving it so many calories, but then deliver adequate amounts of protein, and let's make sure that we meet macronutrient goals. The same that permissive underfeeding does, hypocaloric nutrition will maintain gastrointestinal trophism, will facilitate a caloric starvation response, with the concept that patients now can mobilize their lipid stores and maintain anabolism. But for how long? And the idea is that because we are feeding other nutrients, including protein and micronutrients, but feeding less calories, the patient can mobilize his or her own lipid stores to achieve adequate energy utilization, again, using part of his or her own lipid stores. This idea of hypocaloric, high protein nutrition is now supported by two observational trials. And as I will show, by a third trial that is coming, and hopefully will, that we have reported in an abstract form, and hopefully we'll be publishing in the near future. First study was by Zuzman et al. And was reported and demonstrated by by Dr. Saavedra. And I'm not going to go over it except to say that meeting 50% to 70% of the caloric goals achieves and seems to achieve the best clinical outcomes, while increasing protein goals above that of 1.3 grams per kilogram per day is associated with higher mortality. A similar result is observed in an independent review of 843 patients in the Netherlands by Peter Weiss and colleagues, again demonstrating that about a 20% or so deficit in calories achieves better goals and better outcomes, while feeding more protein above 1.2 grams of protein lowers mortality. And so based on that concept, and based on the clear conclusion that we do not need to meet calories, the question then becomes, how should we feed the patients? And do we really have the right tools to feed optimal amounts of calories while delivering higher amounts of proteins to the critically ill patients? So we did a phase 2 trial evaluating the possible metabolic effects of a formula that delivered more protein and less carbohydrates to these patients. And we focused on overweight and obese patients, again, because we knew that those patients could potentially mobilize their own lipid stores to achieve their own caloric needs. And we developed a study that has come to be known as the DIVINE study. I emphasize that this was a phase 2 clinical trial focusing on safety and metabolic effects. Let's go and dive into this. We did 7 academic centers. We did a prospective open-labeled multi-center trial in mechanically ventilated critically ill patients that had BMIs of 26 to 45 and that were fed for at least 5 days. If you look at the nutritional goals that were achieved on the table, we fed significantly more calories, about 30% more calories in the control group using a traditional formula compared to an experimental formula. But we fed about 50% of the carbohydrates in the experimental group that were fed in the control group, and we achieved with the purpose of achieving the same amount of protein. So the goal of the study was to achieve the same amount of protein with a lower caloric intake. And indeed, if you look at the figure on the lower part of the graph of the slide, we see that every day we were able to achieve a differential amount of calories while delivering, and I insist, the same amount of protein. And what are the results? We analyzed as an intervention intent to treat analysis 102 patients, and what we achieved was a significant decrease in hyperglycemic events defined as blood sugars above 150 milligrams per deciliter. Interestingly, we also observed a significant increase in normal blood sugars reported as being blood sugars between 80 to 110 milligrams per deciliter, without any effect on blood sugars between 110 and 150 milligrams per deciliter. As I will show in detail later, we also achieved other interesting goals in management of blood glucose, including a different average blood or lower average blood glucose and a lower insulin administration. We also looked at other metabolic effects, including that of measuring alkaline phosphatase, and demonstrated that in the control group, there was a progressive rise in alkaline phosphatase, while in the experimental group, alkaline phosphatase remained normal, so that by the end of 7 days, there was an almost 30% difference in alkaline phosphatase between both groups. There was also a significant decrease in carbon dioxide in the experimental group compared to the control group. Let's look at the averages, and this graph becomes very important. As you can see compared to the control group, and the bold line in the middle of the box plot here observed, there was a 12-point difference in blood sugars alone. That is, patients with receiving the experimental formula had a significantly lower blood sugar. As importantly, if you look at the dispersion, meaning the range of blood sugars measured between the lowest blood sugar and the highest blood sugar in both groups, was also different and statistically significantly different. This is called by some the dispersion or variability. And what you see is that there was a significant decrease in the dispersion of blood glucoses in the experimental group, with lower hyperglycemias and a trend to less hypoglycemias or severe hypoglycemias, although that did not achieve statistical significance. So there was a lower dispersion, a lower incidence of hyperglycemias, a decrease in insulin utilization, and hypoglycemic events were not increased. And these are important metabolic differences. Now, do they have any clinical significance? Is this of other importance other than it makes it easier for clinicians to achieve better blood sugar control? Is there anything else? Well, let's look at the mechanisms of how these formulas could work, and these very high protein formula, a low carbohydrate containing formula could work. We know that high protein, that there's at least 5 reasons why this formula works. One is that high protein loads improves insulin sensitivity. The second one is that the type of protein makes a difference. Not only whey makes a difference, but whey peptides and how it is presented make a difference in insulin sensitivity. We also see that this formula lowers carbohydrate delivery, which is obviously associated with better glucose control. And Interestingly, also contains medium chain triglycerides, which are now known to be insulinotropic. So there's a complex interaction of macronutrients that helps achieve better control, glucose control, with this formula in critically ill patients. Let's dive a little bit deeper into this. Glucose-mediated insulin release is triggered in a biphasic production, and is associated with a phase one, which is associated with the direct effect of nutrition, particularly the use of carbohydrates, and a second phase that is associated with the release of GLP and GIP. We know that whey peptides may control GLP and GIP by increasing their release from the stomach, but also by inhibiting the breakdown in the colon by dipeptidyl peptidases. And so there is an importance on why to give whey peptides to these patients. Not only because of intolerance, but because they have an insulinotropic effect. Similarly, medium chain triglycerides, as can be seen in this graph by Eckel and colleagues in 1992, is associated with better insulinotropic effect and glucose control. Now, this formula has been tested in trials of equivalency with other very high protein containing formulas that have different protein and lipid and glucose or sugar carbohydrate contents. And as you can see, there is a significantly blunted effect on blood glucose with the use of this formula in diabetic patients who took one dose and then were followed with a glucose tolerance test. So what about a protein? So I think we have made the case now that clinically we do not need to give as much carbohydrate as we used to believe that was needed in our patients, that there is a concern for higher glucose and exacerbation of hyperglycemia with the traditional higher glucose containing formulas, and that these formulas at least are safe. But what about protein? Is there a benefit from protein? Because these formulas in this particular high hypocaloric, high protein containing formula is going to deliver more protein, or is it? And we know now that in different studies that indeed we can give higher protein delivery with this type of formula. And what we see is a significant increase in the protein delivery. That is, the tool, a very high protein containing enteral formula, is associated with a significant improvement in the delivery of protein and makes it easier for you as a clinician to deliver high protein while avoiding excessive caloric goals and excessive carbohydrate loads. Now, does that make a difference? To do that, we need to look at the types of patients that we see. And we are all aware of the studies in the 1970s by Butterworth, where we looked at the skeletons in the closet. And indeed, malnutrition continues to be a real issue in our ICUs. But the profile of our patients is different. This is a retrospective analysis that was conducted at Geisinger Medical Center and published in abstract form both at Aspen and at in Brussels in 2019. And what you see here is the demographics associated with the different BMIs. Up to 40% or more of the patients that were studied in our ICUs had BMIs greater than 30, and almost 70% of the patients had BMIs greater than 25. We rarely see any more patients with BMIs lower than 20 or so. And thus, this becomes really important because these patients have protein malnutrition But if we can mobilize their calories, those patients should indeed be able and have the resources to have their lipid profiles or their lipids mobilized. What we were able to do retrospectively in this trial that we have called the MIGHTY trial was to demonstrate and to evaluate patients in standard enteral formulas containing low protein versus formulas that we traditionally call high protein formulas containing 25% or so protein, and formulas and a formula that contains a very high amount of protein. Indeed, in fact, it's 37% protein. And because we now have over 2,000 patients analyzed, what we see, and we can look in a retrospective fashion, is we can see the effects on mortality within the hospital, which is in the dark blue, where there is no difference, but at 30 days. And what we see is a significant effect, or at least association, between the amount of protein delivered and the formula utilized and mortality. The higher the protein, the lower the mortality. We have gone on to do a multifactorial analysis to look at confounding factors such as BMI, age, gender, diagnoses, and we find that the effect of a high protein, low carbohydrate containing formula appears to be an independent predictor of improved outcome measured as mortality. And so this data now supports the observations by Zussman and by Peter Wise, and is now a third article that demonstrates the same benefit of increasing protein while lowering carbohydrate loads. I want to thank everybody for giving me the privilege of presenting, and we will take any questions. Thank you.
Thank you, Dr. Ochoa and Dr. Saavedra, for very informative presentations. So our first question will be directed to you, Dr. Ochoa. The DEFINE study showed that blood glucose control could be optimized in ICU patients with a very high protein, low carbohydrate, peptide-based enteral feeding. Insulin requirements were decreased. Why is this significant? Isn't it true that insulin is anabolic and therefore a good thing to have?
So the data on anabolism has been evaluated in the past. And in fact, what we are seeing is that the amount of insulin and the duration of insulin utilization in the intensive care unit is actually directly correlated with side effects, including variability, the potential for hypoglycemia, and mortality. So the more insulin you have to give, the potential for side effects and worse outcomes are associated. So thus, even though in paper, the idea of anabolism appears to be nice and interesting, the truth is that insulin is a difficult tool to use, and it has been associated with poor outcomes if excessively utilized.
All right, thank you. And Dr. Saavedra, what protein to energy ratio is optimal for early enteral feeding?
Thanks for the question, Cindy. I'll certainly ask Juan to comment on this, but even looking at, well, first there's the experiential data that Juan discussed, where we're talking about formulas which contain at least 35, if not slightly higher % of protein to energy ratio. What this does, if you look at roughly, the numbers as it relates to delivering about 70% of resting energy expenditure, anywhere between 16 to 20 calories per kilo per day. And you deliver, about 2 grams of protein, which is, 8 calories per kilo per day. Roughly, you end up with needing to deliver more or less an enteral nutrition that has somewhere between 35 and 40 or 42% protein. So when we talk about the very high protein, these are the percentages that we're talking about. And I just want to add that as we say it's high protein, it is also, of course, lower in carbohydrate with all the consequences and metabolic consequences that Juan actually addressed. I'll make one more addition to the benefits of decreasing carbohydrate versus protein is the fact that carbohydrate, in fact, and the concentration of sugar, especially when provided as maltodextrins or other forms of less absorbable carbohydrate, when it comes to a injured gut, are more significantly associated with intolerance than the amount of protein. Carbohydrate in very large amounts will lead to more gas, more distension, etc., rather than more protein. I don't know, Juan, if you have any other comment.
Exactly the point. I believe that the traditional idea of 150 to 1 protein or calorie to protein ratios is just not, while interesting in normal populations and potentially useful in very stable patients, let's say at home, the data has demonstrated right now, without a doubt, is not how we should be delivering nutrition to our critically ill patients. And I think it is time to give up on this idea that it is okay to continue to deliver high amounts of calories to meet, quote, nutritional goals, particularly early on in the critically ill patients. For how long do we now change the ratio of protein to calories? That remains an interesting question in the literature. We do not know. We do not know when to stop. I do believe and use it in my own practice that if I have a patient that can and is mobilizing their own lipid stores, I will tend to use their own lipid stores to their advantage. By doing this approach that I've demonstrated and I've showed you all in these studies that demonstrate not only a safety, a very clear safety profile, but a potential clinical advantage.
So then should our takeaway be that following a hypocaloric, hyperproteic protocol in the ICU, all of our patients would benefit across the ICU, so our normal or overweight or obese patient, everyone, and not just the overweight and obese patient?
So I think the safety that we have shown is in overweight and obese patients. I will be a little bit more cautious in normal patients, and I will go back to traditional formulas in patients that are severely underweight, where they don't have the fat stores to be mobilized, and where we have data, albeit quite old, but we have data that feeding these patients with severe protein calorie malnutrition, what we used to call marasmus, at caloric goals is beneficial. And in those patients, I do give a traditional formula.
All right, thank you. Another question, and this could be, I think, an hour lecture in itself, but it says, can you please address effects of early enteral nutrition on mitochondrial integrity, and are these studies available?
Yeah, Pepe, I don't know if you want to chime in. I will say something, which is, while we still insist, and when I say we, is the guidelines and the different societies still insist on early enteral nutrition, and there is a benefit to that, including avoidance of atrophy of the gut and maintenance of microbiome and other benefits. While that is important, and I do insist that the guidelines do suggest to start early, meeting caloric goals is not as important, and therefore there is a possibility of a discussion of how much to meet. And then there's the question of what are we doing to our mitochondria. Some researchers suggest that too aggressive of a nutrition, including too aggressive a protein, might be deleterious for protein, for mitochondria, and for other cellular functions. Others, that data, while theoretical and interesting, is not supported by the observations of Sussman and Peter Wise and our own observations. Having said that, what we see is that most of us now start early enteral nutrition, and we carefully ramp up to provide what the guidelines suggest, which is meeting 50 to 70% of the calorie goals in the first week, while we try to deliver 125 to 150% of the protein that we thought we traditionally were given, so above higher protein needs.
All right, thank you. Dr. Saavedra, I think this will be our last question as we're running out of time. But since dietary peptides are absorbed best, is there really any benefit for amino acid-based formulas, or what would their use be?
So amino acid-based formulas for sure would have a role to play in any patient where there is either a history or there's been an allergic reaction to the proteins that are delivered. In this case, either bovine proteins, which are the most common allergic trigger from food across the board. Of course, amino acid formulas may be indicated in that particular situation. Outside that situation, as it relates to specific digestion and absorption of protein, the fact is there probably is very little advantage. First of all, we're not using the most relevant transport system as it relates to amino acids. That's number one. Number two, we're relying on the amino acid profile that is being delivered. And we honestly do not know what an ideal amino acid profile is to deliver to individuals, which we would theoretically need to tailor to the abundance of the specific types of amino acid transporters that are present in the apical membrane, which also varies during critically acute or ill situation. And the last piece, of course, is that if we deliver only amino acids, or the more amino acids we deliver, clearly then we might in some situations get to levels of osmolality if we want to deliver very high protein, because we're talking now at a very high concentration of protein, meaning very high concentration of amino acids into enteral feeding, that does now start moving way above the average osmolality levels of most enteral feedings today. So little potential benefit and potentially some disadvantage.
All right, thank you. I'd like to again thank you both for a wonderful educational program. On behalf of the Nestle Nutrition Institute, we hope that you found this information useful to your practice, and please enjoy the rest of your day.